All right, at this point, I'm going to turn it over to my colleague, Dr. Alice Wang.
Thanks, Dr. Masterson. Great talk. Hi, everyone. My name is Dr. Wang. I'm a urologic surgeon with Dr. Masterson at Brandywine Urology. I specialize in female and male reconstruction. So basically incontinence in both men and women, and obviously work very closely with Christiana Care as well. I'm from Chicago originally, went to med school there, then went to Vanderbilt to do my residency, and then did a fellowship in female and male reconstructive surgery at MUSC in South Carolina, and then joined this practice just about almost 3 years ago at this point. Next slide. So much like the slides for erectile dysfunction, Boston Scientific also has some great resources for male incontinence as well. So we'll just give a second for anyone that needs to or wants to scan this QR code to basically help get a better understanding of what's going on with your incontinence and how we can help you. Okay, we could probably go to the next slide. So we're going to focus a lot, obviously, basically the talk on my side about male stress incontinence. And unlike Dr. Masterson's talk on ED, for the most part, there are a few exceptions, but for the most part, when men develop stress incontinence, it's usually because of a surgery that they had or maybe some radiation treatment. And so it doesn't usually happen in men kind of organically. So stress incontinence specifically is leakage of urine with some kind of increased activity or pressure on the bladder. So movements, swinging a golf club, picking up a grandchild, these are all things that can cause leakage of urine that we define as stress, coughing, laughing, etc. It is quite common. I mean, if you look at the stats here, about 13 million men suffer from stress incontinence. And in the United States alone, 17,000 new men develop bothersome stress incontinence every single year. So it's definitely a problem that's out there, and luckily we have some good solutions for it. Next slide. So just a quick, anatomy kind of overview. This is a picture of a male kind of cut. If you think about it, down the middle, kind of laterally. So it gives an idea of where the bladder is located at, where the prostate is, and then kind of that muscle right underneath the prostate called the external sphincter that helps hold in urine normally. And then obviously the urethra, which is within the penis itself. So the job of the bladder, as most people know, is to store urine. When you want to pee, the urine then exits out that tube called the urethra. There is a muscle that we just talked about. There's actually two different areas of continence in men, one right up by the bladder, then that external muscle tissue right underneath the bladder, prostate as well. That muscle is normally contracted. So that's why normally, if you haven't had any kind of surgery or any kind of radiation or treatment down there, that muscle is constantly contracted and helps hold in that urine and prevents the leakage. When your bladder is full through a numerous kind of spinal and brain pathways, that muscle then relaxes, which allows for your bladder to then contract and the urine gets pushed out and evacuated. Next slide. So, like I kind of alluded to, the most common cause of stress incontinence in men is the removal of the prostate, so the prostatectomy. Certainly radiation or a combination of maybe some hormone treatments and other things can also affect the ability for that muscle to contract and hold in the urine. Other causes of male incontinence, people who've had, BPH, so enlargement of the prostate, non-cancerous enlargement, and have maybe had some surgeries for that enlargement can also develop stress incontinence. Sometimes patients with spinal cord injuries can develop stress incontinence. If you've had other kind of pelvic surgeries, urethral surgeries as well, those can also be causes of incontinence. So understandably, and I think everyone here can agree that can severely impact quality of life. So, I see it in my patients that I see before surgery that have stress incontinence. It really does kind of consume their life and their ability to do activities and kind of live their life to the fullest capacity. And so unsurprisingly, it's associated with a higher, chances of depression. And of course, unsurprisingly, the worse the incontinence is, the more likely the depression is going to be there. So let's talk about what we can do to help fix this problem. So prostate cancer, as we all know, is one of the most common, is the most common cancer in men, and about 90,000 prostatectomies are done each year in the United States. That's quite a bit. And if you think about the statistics, about anywhere between about around 10 to 16, 20% of men, unfortunately, have persistent, what we call post-prostatectomy incontinence, even after 1 year after they've had surgery. So just quickly, I think Dr. Masterson already kind of alluded to the surgery itself, but the prostate's circled there in that first picture. The prostate's removed, usually again for prostate cancer reasons, and then the urethra and the bladder are then sewed back together. Okay, so options. So starting from kind of, I don't know if invasive is really the word, but I guess non-procedural. There's definitely behavioral changes you can make, right? Drink less fluids, make sure you urinate on a certain schedule. But both of those things are oftentimes difficult to do, and sometimes are not feasible, especially if you're traveling or if you're out somewhere. Some non-surgical options are pelvic floor physical therapy. Definitely, I always push for pelvic floor physical therapy in my patients when I see them. Kegel exercises, a pelvic floor strengthening exercises, and then a component of that is biofeedback, basically where they basically kind of give you your own body feedback when you're doing certain things to kind of see how you're progressing. Now, I will say with the caveat is that, again, I see a lot of women with pelvic floor dysfunction and urination issues, and I think pelvic floor physical therapy works very well for those patients. In my men who have had, again, usually a prostate removed, tends to not be as successful because there's a surgical reason why you're not able to hold in your urine, and that's difficult to replace with pelvic floor alone. But again, never a bad option, always out there. And then I think coping, I mean, there's pads, diapers, there's catheters, there's penile clamps you can put on. My patients have tried all these things. Again, feasible, easy to understand. Everyone knows what a pad and a diaper is, but in terms of, quality of life, not that great. Not really a great solution. So there's really two kind of surgeries that we'll talk about today. The first one is called the advanced male sling. And so this is a really good option for men who have what we call mild to moderate stress urinary incontinence. And obviously that's very subjective. But when I meet my patients for this first time, I often ask them, okay, well, how many pads are you soaking through a day and how wet are they? And sometimes if I'm not completely clear or it's really variable, then I'll have them bring in the pads. My nurses love that. And so we weigh all the pads, we weigh how much urine's in there, we subtract the dry weight, and we figure out exactly how many grams per day you leak urine. And based on that number, we kind of are able to counsel you better about what's the best option for you in terms of your treatment. This is a minimally invasive procedure. It's an outpatient procedure. It takes usually about 45 minutes to an hour to do. You should be able to go home that day. And the nice thing about this procedure is that once it's in, you're kind of done. Like there's no devices, there's no pumps, there's nothing you do. It's in you, and you're good to go. And I do find that when it's picked for the right patient and they're counseled appropriately, it works really well, and the patient satisfaction rate is extremely high. And one study, here reported reduction in pads by 77%. I will say that I never quote 100% dryness in my patients because I don't think that that's a very fair thing to promise. But in all the slings that we've done together, Kevin and I and Megan and the whole team, I haven't had a guy yet that has not had reduction in their incontinence pads, usually very significantly. All right, next slide. So how it works. So this is if you're looking at a man's pelvis and it's facing you. So up is up and down is down, and then the urethra is kind of right in the middle with that tissue muscle kind of surrounding it. So the idea is that you basically put in this mesh sling that acts like a baby hammock. That's the way I think of it. And so we basically tighten it under direct vision, so it kind of provides just enough resistance so that when you move, swing a golf club, laugh, cough, and sneeze, pick up your grandchild, it provides that resistance to hold in the urine. The incision that we make is about 3 to 4 centimeters, kind of right in that area between the scrotum and the anus. And then you have two little stab incisions kind of right on the inner groin creases. And that's the only incision that you have. And again, patient satisfaction rate tends to be very high. It's usually recommended once you've gotten it. People talk about it to all their friends. The next option is called the AMS 800 artificial urinary sphincter. This one is what we consider the gold standard treatment. And the reason we say gold standard is that it works for men who leak a little bit, mild stress incontinence, and it works for men who leak a lot. And it also works very well for men who have had radiation therapy. Now, for the male sling that we just talked about, some people will not do the male sling for patients who've had radiation because the tissue tends not to be as soft and pliable. I will do it if it's for the right patient, right? They have to leak a little, not a whole lot, and we have to make sure that the tissue there is nice and soft. But I think it's not a direct contraindication for me to not do that procedure. But the reason why the AUS is considered, again, the gold standard is because it works for every type of incontinence: leak little, a lot, radiation, no radiation. So this one does it mimics the way the urethra normally kind of the muscle around there kind of shuts off when you don't want to urinate, but it does require some manipulation, meaning that there is a pump that you have to use. But obviously very, very easy, patients don't normally have a problem with it, but it has to be operated by the patient. All right, next slide. So here it is. Here's the device. So it's really kind of a three-part device. So again, the urethra you can kind of see going down the middle of the penis here. And so there's a cuff that's around that urethra, and every one is measured. We measure every single urethra when we do this surgery. So every guy's a little bit different. And then you also it's connected to a pump, which is going to be in kind of the anterior part of your scrotum. Laterality just depends, on what handedness people are. And then there's also a reservoir called the pressure regulating balloon that kind of sits right in that in the lower pelvis area, right behind that bone. And so the way that it works is that when you don't want to urinate or you don't want to leak any urine, the cuff is inflated with fluid. All right. So if it's inflated, it's squeezing that urethra shut. Okay. And then via a pressure valve mechanism, when you want to go to the bathroom, your bladder feels full, and you stand over the toilet or sit down, whatever it may be, and you squeeze that pump one time. And what that does is it basically releases the pressure around the cuff and squeezes all that fluid around the cuff into that reservoir, okay, that's hanging out in your belly. And again, because it is a pressure valve mechanism, when it hits a certain pressure, which usually takes about 60 seconds, the fluid will then shoot back into that cuff, and then it will close off again. So the only time you ever have to use it or push that pump is just one push when you want to pee, and then 60 seconds later, it'll close off by itself again. And so we just have a quick little demonstration video that shows how it works. So here you go. You see the cuff around that urethra. You see the pump kind of sitting in that scrotal area. One quick little push, that little pump will depress, a dimple will happen, and you'll feel that, and you'll see that fluid travel out, go into the reservoir, and it'll stay open. 60 seconds later, once your bladder is empty, because most people could empty their bladder less than seconds, it'll close back off again. All right. So for all of these procedures, including the sling as well as the AUS, they're all for the most part outpatient procedures. The sling has that one incision with the two small little stab incisions. The artificial urinary sphincter has a similar 2 to 4 centimeter incision in that area between the scrotum and the anus, and then also a small incision either in the right lower quadrant of your abdomen or the left lower quadrant, depending on your handedness. Usually we recommend, keeping the scrotum elevated, ice on, ice off for a couple of weeks, take it easy. And then we don't activate the device. This is the AUS, excuse me, not the sling, for about 4 to 6 weeks, because we have to allow that area to heal before we're able to use it. Okay. So what does the data show? How happy are patients with it? Do they recommend it to other people who have a similar issue? And the answer is a resounding yes. I knock on wood, I have not had an unhappy customer since I've put in these devices. Most men are very, very happy. and report a very, significant increase in their quality of life after this procedure. And I think, the numbers show itself. I mean, the fact that over 90% of patients would get the AMS again, the artificial urinary sphincter again, 800 is pretty impressive. And most of the time, even though some of my shyer patients in the beginning, they may not want to talk about it when they're talking about getting the surgery themselves. Once they get it, they're ready to like go on the top of the rooftop and shout it out to their friends. I mean, they're pumped, they're ecstatic, and it's really heartwarming to see because they want other men that are in their position to know that there's hope and there's treatment options and in their quality of life, they can still, they can really regain that. And so now, long-term studies, I think here you go, right here, you can see kind of, where people are at in terms of percentiles of how, are they continent or how many pads are they using? So again, very impressive. I tell my men, once that male sling goes in, it's with you until you die. Usually you don't need, if it's working well for you, then you keep that. And usually you don't have to replace or anything like that. Now, the artificial urinary sphincter is a mechanical device, right? So over time, just like the inflatable penile prosthetic, it can develop issues. Either it doesn't close off completely or the pump's not functioning. Normally, this is about at least 10 to 12 years down the line. So I tell my patients, so we may have to revise it at some point. So that is a possibility with the artificial urinary sphincter. Okay. So, from my perspective, and maybe Kevin and Megan can touch on this, I have not had any issues getting this surgery covered. I think sometimes, unfortunately, erectile dysfunction, insurance companies can be a little bit more iffy about coverage. But in terms of stress incontinence for men, I've not had that issue. So luckily, it's usually covered by all insurances. And of course, we can work with your insurance. They've got a special team at Boston Scientific to work through that. And we always run our own like we always check your insurance companies before we do any kind of surgery to make sure that it's covered before we would do any kind of surgery on you. So, there's a great resources through Boston Scientific about patient testimony, people willing to talk to you about it. If you're interested in getting this surgery, we've got our own patients in our own clinic that I've talked to that would be more than willing to talk to you about it as well, face to face or whatever is the most easiest. And so there's really good testimony out there, and they'll be truthful too about the recovery, how it was, how painful it was, what they did, what worked for them, etc. So again, I mean, I think men and women understand what the benefit of, stress incontinence treatment is, right? Like getting your quality of life back, being able to do the activities that you love, not having to carry around a million pads all the time and changing it about worrying about the smell. I mean, this is all things that we're hoping to try and fix. So possible risks. Yeah. So, any surgery has risks about it. And I think Dr. Masterson and I are kind of on the same page where we'll tell you everything about the risks, right? Like we don't want to talk anyone into surgery. We want to make sure that you understand exactly what's going to happen and the risks associated with it, though very rare, because ultimately it's your life and you got to make the best decision for yourself. So with the sling, certainly you cannot be as dry as you want to be, right? Again, there's only a certain amount that we can tighten that string. We can't a sling, excuse me. We can't make it any tighter because then there'll be issues. And so sometimes it doesn't work as well as we'd like to, right? There's always pain after surgery. Usually that goes away. You can get an infection, you can get irritation at that wound site, all these things that concur with surgery. Again, pretty rare. And then retention, right? So if you're having a hard time emptying your bladder, usually I will say if that does happen, which is pretty rare, leaving a catheter in for a couple days to allow the anesthesia to kind of wear off, the swelling to come down usually fixes the problem. With artificial urinary sphincters, sometimes we have to revise it, right? A lot of the times it's because it's been used for many, many years and the device is kind of worn down. We need to put a new one in. I will say in all of my almost all of my men that I see have had an AUS and it no longer works before. I have not met a guy that said, forget it. I don't want it replaced. Almost every guy is like, oh, I need it replaced and let's do it now. So sometimes it doesn't work though. And sometimes we have to go back sooner than what we like and replace it. There are certainly risks of erosion or damage to the urethra that can happen during this surgery. We do a lot of kind of precautions and to kind of prevent that from happening. There's a lot of different strategies and tips and tricks that we do, but that's certainly possible. Sometimes the swelling precludes people from emptying their body immediately. But again, usually leaving a catheter in for a short amount of time fixes the problem. Infection is our biggest concern with this type of surgery because it's an implant. And so we really, really are very careful. We are very sterile. We give very strong antibiotics beforehand to kind of help prevent infection. And luckily that risk of that is pretty low. All right. So, summary, this is not, I have men come up and ask me, it's like, why did this happen to me? I thought I, had a really successful surgery, and they're just kind of disappointed about, this outcome. And I always stress that this is a known potential side effect of the surgery. It means nothing in terms of what happened in surgery. It has nothing to do with how well you healed or how strong you are or anything like that. It's just when you take out the prostate, the areas of continence also get disturbed. And sometimes it's affected more than others. And a lot of times, obviously, the priority of the surgeon is to get rid of the prostate cancer. And so sometimes these things just happen. But luckily, there's been a lot of good advances in treatment options, more than just pads and diapers and clamps. And so there's definitely hope. And there's really good data and really good patient testimonials to kind of back that up. And again, there's a great resources and other ones listed at the bottom there. Okay. I think we have a question in the chat box.
All right,
Oh, maybe,
super.
actually, you know what? Maybe not. I'm sorry. Maybe I thought I did, but I might have misspoken.
And if anyone is watching us on Facebook Live, feel free to type your questions in the chat and I can read them here.